Hereby, I open this academic ceremony in which Idah Mokhele will defend the academic thesis, The Development of a Contextually Relevant Motivational Interviewing Counselling Training Program for Lay Counsellors in South Africa. May I invite you to present a summary of your study and the conclusions of your thesis?
Thank you. Dear Rector, members of the Assessment Committee, supervisors, it is with great pleasure that I take the opportunity in the next 15 minutes to present the summary of my PhD thesis titled The Development of a Contextually Relevant Motivational Interviewing Counselling Training Program for Lay Counsellors in South Africa. HIV continues to be a major global public health issue, with an estimated 39 million people living in HIV at the end of 2022, with 1.3 million new infections and 630,000 deaths reported in the same year. South Africa has the highest burden of HIV, accounting for 20% of the global burden. That means that 20% of all people living with HIV are in South Africa, and almost 20% of new infections occur there too. And antiretroviral therapy has significantly improved the quality of life for those living with HIV. And South Africa has made significant investments in its national treatment program, and as a result, has the largest program in the world, which has undergone further expansion through several strategies and policies the country has adopted over the years. The country committed to the UNAIDS fast-track targets to end the epidemic by 2030. These targets are that 95% of people living with HIV know their HIV status, 95% of whom actually are initiated on antiretroviral therapy, and 95% are virally suppressed. To achieve these targets, the country also adopted the WHO-recommended universal test and treat policy. The policy is that all patients, it eliminates the CD4 count threshold eligibility requirement to be initiated on treatment, which means that all people living with HIV now are eligible for treatment. They also implemented the same-day initiation of treatment strategy, which meant that patients should be initiated on the day of diagnosis to prevent losses to treatment. Though these actions are commendable by the country, there are still gaps in terms of treatment uptake, with only 75% of those who know their HIV status initiated on treatment. And among those initiated on treatment, 92% are virally suppressed. HIV testing services are the entry point to HIV care and treatment services. And in South Africa, lay counsellors are at the forefront of HIV testing services and providing psychosocial support in primary care. In the current context of universal and early treatment, good quality counselling is critical to help people living with HIV navigate the implications of their HIV diagnosis and remain motivated to remain in lifelong treatment. However, lay counsellors typically have little formal training and varying levels of capacity, experience, and counselling certification. Because of this disparity in their training and educational background, their levels of the skills, their knowledge, and approaches to counselling have been found to be varying. And with the current and evolving landscape of HIV care, it requires the strengthening of their capacity to be able to be effective as important agents in influencing patients to take up treatment and be able to take care of their needs as such. Motivational interviewing is a counseling approach that could enable these lay counsellors to effectively assist their patients to take up treatment and remain on treatment. The overall spirit of motivational interviewing, which is essentially the interpersonal relationship within which the approach is applied, is based on these 4 key principles, and the idea that motivation is crucial for client behavior change. It also acknowledges that the client themselves, they're a key decision maker in their own life. There is evidence supporting motivational interviewing use in smoking cessation, alcohol, and substance abuse studies when applied by therapists and clinicians. However, training, there's limited information regarding the training that's been applied for these providers, and training issues are very critical in motivational interviewing, as as acquiring the skills is important, but also ongoing practice is important in terms of maintaining the skills. Therefore, investment in training is necessary for impact in change in practice. Considering this background, studies in my PhD thesis were divided into 3 phases, applying mixed methods research approaches undertaken among healthcare providers, lay counselors, and people living with HIV between 2017 and 2021 in primary healthcare facilities in Johannesburg. In study 1, as part of the needs assessment, we sought to understand the perspective of the healthcare providers as the implementers of these new policies. And we did that through qualitative interviews. We found that providers were generally knowledgeable about these policies, and they regarded them positively. And they highlighted the clinical and public health benefits. However, key barriers were highlighted, including the increase in workload, coupled with limitations in terms of infrastructure and human resources. Implementation of the same-day initiation of ART strategy was not well understood. It was inconsistent. Was it the same day? Was it within a week? Was it within a month? Providers were not clear. Providers also raised challenges with client readiness to be able to take up treatment immediately after diagnosis. However, they didn't have strategies themselves in terms of how do we then identify these challenges and how do we then deal with these challenges. And the providers also raised issues with lay counselor capacity to be able to manage clients' uncertainty in terms of taking up treatment on the day of diagnosis, especially amongst those patients that may have been diagnosed at a relatively healthy state and may not see the benefits of starting treatment early. Therefore, what these findings tell us is that there's a need for further engagement with healthcare providers regarding policy implementation, and also, importantly, addressing some of the gaps in policy implementation, including resource support, and also providing detailed guidance in terms of implementation. In study 2 of the needs assessment, the focus now shifted on the demand side of HIV care. With expanded access to treatment, it was important to understand the motivators for seeking care among people living with HIV. So we surveyed newly diagnosed patients to assess their motivation for testing for HIV when they were diagnosed, and considered those reporting ill health as the main reason for coming for testing as motivated by symptoms. Results show that almost 2/3 of newly diagnosed patients enrolled in the study were actually motivated by symptoms, and symptoms when they were diagnosed. And the main predictors that we found of symptom-related motivators for HIV testing included low or missing baseline CD4 count, non-disclosure of intention to test to the main partner, and also HIV testing history. These findings highlight that there are gaps in terms of people living with HIV and seeking early HIV treatment or early HIV care in order to benefit from these increase in treatment access. In the final study of the needs assessment, we actually sought to understand lay counselors, our main target population, and their current work context, and also shed light in terms of what are their needs and what is their capacity to be able to provide good quality counseling in this current policy. Almost 90% of lay counselors enrolled in the study were Department of Health lay counselors who were receiving a volunteer stipend at the time. And almost a quarter were also themselves living with HIV. Results from the survey show that lay counselors actually still face operational barriers in their work environment, with 60% reporting to be feeling overwhelmed by their workload. Disparities in training were also notable, with some of the lay counsellors actually reporting major depressive symptoms and low psychosocial wellness. So results highlight that, the lay counsellors are still challenged in their roles. They still have persistent unmet psychosocial training, professional, emotional, psychosocial needs, and this could impact their effectiveness in terms of implementing these policies. Study 4 outlines the intervention development process we undertook to develop our training intervention called the TUSA Motivational Interviewing Training Program for Lay Counsellors. We developed the training intervention based on evidence we gathered from literature and also evidence we gathered from the needs assessment that we conducted. We incorporated the socio-ecological model or perspective through ongoing engagement with lay counsellors, clinic managers, who are their supervisors, and district managers who actually oversee their environment. We included theory-based training approaches in the training, which provided a robust, reliable, and adaptable framework to ensure effective learning and development. We also incorporated quality assurance for skills development using validated approaches to assess competency in motivational interviewing counselling. This also served as a self-assessment for the counsellors to improve their self-efficacy during the training. Additionally, we included a self-care component to try and assess that, to try and support their emotional and psychosocial support. The final training that we developed is relevant to the context and target population. And it has training components that reflect the program's purpose and intention, which is to improve motivational interviewing counselling among lay counsellors, to improve treatment uptake and also retention in treatment for patients. In the last study, the last study involved evaluating the training intervention, and we used mixed method approaches, firstly among the lay counsellors who participated in the pilot training, and these lay counsellors were from 10 primary healthcare clinics in Johannesburg. And in terms of the competency scores that we saw, that there was an overall improvement in terms of their competency over the 12-month training period. And from focus group discussions, after the training, the counsellors actually reported, positive experience and highlighted how the training helped them get back to patient-centered counselling. And they also, said that it improved their confidence and their motivation in their work. Findings from this evaluation actually showed acceptability and feasibility of the training among lay counsellors, which led to a request to adapt the training for dissemination through a training of trainers approach to NGO partners of the HIV treatment program in South Africa. We conducted focus group discussions with these training participants after the implementation of this trainer approach, and they generally reported a positive experience from the training. They highlighted how the training helped them get introduced to motivational interviewing by linking it back to their basic counseling skills. They also highlighted how the tools within the training actually help them support their counselors. So these findings show that, scale up through training of trainers is possible, and, with flexibility for adaptations, but also remaining to the core of the training and the theory and evidence base that was used to develop the training. Overall, the results demonstrate that it's feasible and acceptable to use lay counsellors to actually deliver motivational interviewing interventions. This could help bridge the gap in providing comprehensive psychosocial support at the primary healthcare level. However, more research using appropriately powered studies is needed to strengthen the evidence for impact. Furthermore, the foundation that has been laid from the evidence from this study show that there is opportunity for adaptations to adapt the training to different target population and to target different behaviors. To the policymakers, in order for lay counsellors to be effective, their role should firstly be formalized in the healthcare system. And it should be coupled with adequate resources and skills development plan to address the existing training and support gaps. And integrating evidence-based training approaches, such as the TUSA training program, can help improve their skills, their knowledge, their motivation, and help them have the impact that is needed in the healthcare system. I thank you and hand back the word to the rector.
Thank you very much for your very clear presentation. The opposition will now be opened by Professor Jonas, Professor of Applied Social Psychology at Maastricht University, and he was the chair of the reading committee.
Thank you, Rector, for the possibility to ask questions. Dear candidate, I want to first of all congratulate you for your really nice thesis. I enjoyed reading it, and I think you did a very apt presentation of the needs and the complexity of the HIV epidemic in South Africa, and that we need novel approaches to combat it. I want to ask two questions if I have the time. My first question is really thinking about the future beyond your PhD thesis. Mm-hmm. You showed in your presentation that 58% of these lay counselors consider themselves inadequately trained. Mm-hmm. And now you're presenting one counseling training, motivational interviewing. But do you have ideas what other kind of training content, counseling techniques would be needed to create a better quality of training and decrease the feeling of being inadequately prepared? So what would be need to be added to the basket of counseling and training skills for these lay counselors? Do you have ideas about that, and can you enlighten us a bit?
Highly esteemed opponent, I thank you for your compliments and for your question. So the lay counselor role is a complex role within, the South African health system. It evolved from peer educators, people living with HIV, being support to people that are diagnosed. So, in terms of their training and background, we find that is why it's inadequate. Going forward, just like the way that nurses and other professionals within the healthcare system actually have a framework of how they are managed and how they are, kept their professional standing within, the health system. I think something of the same is needed within lay counselors. Not just once-off training where, if some NGO partner has money to train, counselors, they come and they train them for 3 days and they never see them again. They need ongoing support. They need ongoing mentoring. From what we saw when we implemented the training is that support, that constant, not just quarterly trainings, but actually somebody commenting on your work, sitting in through your counseling sessions, and after the counseling sessions, providing feedback to say, this is where you could improve your approaches. We know that this patient was challenging in this manner, and this is how you can maybe improve your approaches. If there's something like that within the context of how they work in their professional framework, that could be a constant sort of backing in terms of improving their skills and actually helping them feel more confident and motivated to do that work.
Okay, you mentioned the framework that applies to the nurses. Would you apply the same framework? And could you elaborate a bit more on the content of that framework, or specifically tailored to these lay counselors?
Thank you for that question. I think that these counselors need a framework, a professional framework, to professionalize their role. And this would include minimum requirements to become a lay counselor, and also ongoing requirements to remain a counselor. So already in the guidelines that actually guide HIV treatment and adherence support for people in the healthcare system, lay counselors are supposed to receive an annual refresher training. So that annual refresher training should be structured in a way to be able to meet the requirements for these counselors. So improving their knowledge as there's more improvements in terms of research in HIV. Like, for instance, in one of the in one of the interviews with the counselors, one of them actually mentioned that they thought HIV could be cured. Or some of them said, they didn't understand, they didn't know treatment as prevention, as PrEP is something to prevent HIV. So those kind of issues show that, the professionalization of lay counselors requires a framework that actually deals with their basic competency and ongoing competency to be able to make sure that they can be able to meet the requirements of their work environment, as research actually shows that there's improvements in terms of treatment, there's new knowledge in terms of how HIV patients should be managed.
Okay, thank you very much. I'll give the word back to the rector.
Thank you very much. The opposition will be continued by Dr. Ibisomi. She's present with us online. Also a member of the assessment committee, and Dr. Ibisomi is Associate Professor of Epidemiology and Biostatistics at the University of Witwatersrand, South Africa. Dr. Ibisomi, please wait. I think they are trying to resolve the audio problem. Please allow us to continue with the next opponent. We'll get back to you after. The next opponent will then be Dr. Massar, member of the assessment committee, associate professor of applied social psychology at Maastricht University.
Thank you. Dear candidate, also from me, compliments and congratulations, preliminary congratulations, of course. I really enjoyed reading your dissertation. I think also the fact that you have published almost all your chapters, or all of them, maybe by now, is also a sign of the quality and importance of your work. So my questions are also about the motivational interviewing intervention. And specifically the choice for that method to change behavior, because I was wondering whether it was the most appropriate technique in the context of these lay counselors and also in the context of administering HTS. Because I know and I'm very aware of the many benefits of motivational interviewing, but there are also some downside, and I think a few of them are really relevant, specifically the fact that some authors state that to be effective in motivational interviewing, you need time to build sort of a relationship between the client and the counselor. Mm-hmm. And given also your findings that you also just presented, that there's limited counseling time available, and that also the counselors feel that is one of the biggest hurdles in their jobs. I was wondering whether there is enough time for that bond to develop or rapport to develop between the counselor and the individual. And whether then, if you don't have that time and you just have a one-off meeting with someone, whether motivational interviewing is the correct way to go about trying to change their behavior. And the second one I wanted to address is the fact that motivational interviewing, as you also mentioned, the core component of it is an initial motivation. There needs to be at least some sort of, maybe a small kernel of motivation within the individual to actually change behavior or to uptake ART in this case. And again, you report that only 1/3 of the individuals seeking treatment or testing are motivated by risk perception. So I wonder to what extent the combination of not having enough time plus a low motivation or absence of motivation among the clients makes motivational interviewing effective. And I would like you to elaborate on why you do think that is the case and why you chose for this particular behavior change method or technique and not, for example, implementation intentions.
Dear esteemed proponent, thank you for your compliment and your question, and to confirm that all the papers in my dissertation have been published. When it came to motivational interviewing, I think one of the things that I personally came to see with the lay counselors themselves is their lack of motivation. And when you are demotivated as a healthcare provider and you are encountering this person in the most vulnerable state or position, that you need those tools to be able to say, yes, I can motivate you as an external person, but we need to grow that motivation in you so that you can make the decision to say, this is my life, and I will make this decision to start treatment and I remain on treatment for the rest of my life because it's important for me. So in terms of building rapport, so one of the challenges that the counselors, you rightly so stated, that was time. And this time factor is something that the counselors themselves raised, saying that, we have been pressured because we now must meet targets under this, new policies. We must, test so many people, and this many people must be positive. It was bizarre when, I first encountered the counselors to say, how can you have a target of testing, like finding positive people when you're a clinic-based HIV testing service? So I think one of the things that the training itself did for the lay counselors is actually help them understand that their role is more important than just having, shuttling people through their offices to say, are you positive, are you negative, are you positive, are you negative? So what I think this helped them to do as well is actually give themselves that space to build rapport with the clients, to say, you're in my room right now, you're important, let's deal with the priorities that you want to deal with as part of this testing process. If you're positive, let's talk about the implications regarding your a positive diagnosis. How does that affect you personally? How does that affect you with regards to other facets of your life? So it was not, it sort of like also empowered them to say, you know what, I'm busy with a client. Yes, there is a queue outside, but I need to deal with this client to make sure that they walk out of my room feeling that they've been listened to, they've been heard, whatever issues that they've dealt with is their address. And then in terms of getting that motivation to actually stay consistent, to remain motivated, that's why motivational interviewing counseling is so important. And, the way that we apply the training, we also use motivational interviewing to, for the lay counselors, because when they came to the training, they were not motivated because they were like, I don't know who my employer is. I don't know if my contract will be renewed. I don't have workspace at work. So we motivated them to remain motivated to not only go through the training, but to also see the value of their work. And working with clients also helped, also gave them the opportunity to apply the same approach to say, this is you and me, we've built a rapport, and we've come to a place where you have made a decision, and that decision comes from you. And that is seen as something that can be sustained, not somebody telling you, this is what you should do. And then when you walk out the door, something happens, and all of a sudden, you don't see the reason anymore. So that's why I think that motivational interviewing was appropriate in this kind of context, barring the different limitations that it had.
Thank you. That's a very excellent answer, actually. Then my second question is really about...
Please keep it short.
Yes. Okay, then I will ask my third question, which is shorter. What I was actually lacking in the dissertation is maybe interviews with these lay counselors, because you do provide a profile of who they are and what they, how they perceive their jobs and also their intention to quit or to. But I was wondering whether you also conducted interviews with them. Because in chapter 2 you describe healthcare providers, but they're not only the lay counselors, I think. So I was missing this more in-depth perspective, these lived experiences of these lay counselors, and also why they initially chose to become a lay counselor, because I do feel it's sort of a calling and not just a job for most of them.
All right, thank you for your question. So we did speak with lay counselors in the first study, the healthcare providers' perspective, and got their take regarding the new policies. But you are correct that we didn't conduct in-depth interviews to the extent of using qualitative approaches to gather their insights. And, I know I talk a lot about them, like knowing them, but this is, my interaction with them during the project and my interaction with them even outside the training and so forth. So I do acknowledge that, their voice should have come in a lot more within the research.
Yeah. Thank you.
Thank you very much. Then we will now give Dr. Ibisomi again the opportunity to be the next opponent. Dr. Ibisomi, do you hear us? And
yes, good afternoon. Can you hear me?
yes, please go ahead.
Oh, great. Okay, I'll join the others by saying well done to you, Idah, on this significant research. My first issue will be around the structure and the clarification, on chapter 1. Reading chapter 1, one is unable to get a firm grasp of what the research is all about. I will expect the chapter to tell us what you did and how you did it, without having to go into the other chapters. I know that in the other chapters, you have the methodology that speaks to the various things that you did. So I believe there should be a kind of something like what you have in the summary chapter that tells us what you did, that tells us about the various phases and the output. But in this case, it should be about the various phases and the activities carried out within those phases, so that it gives us a sort of idea about what the entire research is about. You remember, you don't have a conceptual framework, you don't have specific objectives. Readers need to have an idea of what you did as a whole, a single story, without going into the other chapters. The second one is about the framework, the figure 1, which you titled Socio-Ecological Model for HIV patients and lay counselors. You did not speak directly to that figure and how it's, you moved from the concentric circles on the left to the right, and where exactly you used it. There's no writing that speaks to that directly. So maybe you can address those, and I also have a small further comments to make here.
Thank you, esteemed opponent, for your compliment and your remarks. So chapter 1, I tried to actually provide an overview of the whole thesis, and may have missed some important framework, as you have understood. But I tried to go in terms of why this was important and why the target population and why the approaches that we used in the actual research. And I note your remarks regarding the gaps in terms of explaining the socio-ecological framework with regards to lay counselors. What I should have said is that they actually exist within an environment which can affect their effectiveness in terms of their work. And this will include the work environment, where if issues related to belonging and actually feeling like you're part of the team have been raised in other research and have been we found in our interaction with the lay counselors. So I take your comment, and I thank you for that feedback.
Okay, thank you. And the last one is about, okay, let me say congratulations on the various publications. In your concluding remark, you actually spoke to the, to the policymakers. And I wonder about how widespread, the findings from your research is. I did not see anything that speaks to maybe conference output, anything that speaks about policy brief, or how you are going to be engaging with policymakers to make this more applicable or widely used. This is something that I feel could potentially benefit even other health programs. So how do you intend to do this engagement for this to be used, to be adopted, more widely, or to be adopted within this program, as well as other similar programs in South Africa and elsewhere?
Thank you for your question. So to confirm that all the chapters that in the dissertation have all been presented in local and international conferences as abstracts, as posters, and as an oral presentation. The last two chapters were presented at the Public Health, the PASA conference in South Africa. And in terms of, engagement of the work with getting the benefit to the health system. So as I mentioned that, we actually scaled up this training and trained NGO partners to be able to train their lay counselors they support. And this is, the national NGO partner to support the treatment program in South Africa, meaning that, not only our little 10 counselors actually got to benefit from the training, that a lot more counselors, not just the psychosocial team that actually we applied the training of trainer approach to, but they actually went on to their support, their clinics that they support throughout the country, and actually trained their lay counselors. So the training has been disseminated, and the reason why we were asked to disseminate the training is that important decision makers within the district, within National Department of Health, actually got to know about the program, whether it's through the publication or through the engagement that we have regarding the training with healthcare providers and key decision makers in the National Health Program. So we have had the opportunity to disseminate the training or disseminate information about the results from the training or the process we underwent in developing the training widely, and also a lot more people have had the benefit of receiving the training and being able to apply these methodologies in their clinics.
Okay, thank you. But I would expect that maybe you are looking at this being adopted, by the policymakers. So what is the feeling that you've gotten in that area, so that it's actually it becomes routine within the South African health system and not necessarily the NGO caucus alone?
On time. Do you allow us to proceed to the next opponent? Next opponent will be Professor Sifunda, also member of the assessment committee. He's research director of Human Sciences Research Council in South Africa, and he's also with us online. Please go ahead.
Thank you, Chair. Dear candidate, congratulations on your work. And I must say, I really enjoyed reading it very much. And it actually, by some coincidence, kind of is aligned to some work that I've been doing recently that's about your research topic, where I've been asked by government to evaluate the policy of these community healthcare workers and your subject matter. And it's been really interesting because you pretty much probably helped my work as well. So I would even tell you a story that happened to me recently as I was asked to go and present some of our findings around the working conditions and what we did the whole country. So you're lucky you only did Gauteng. We actually have been, for a whole year, been evaluating the working conditions of lay counsellors and community health workers in the whole of South Africa. And I would even tell you a funny story before I ask my question, that when I was going to present 3 weeks ago, we go to the Department of Health and there were lay counsellors and CHWs on strike. They'd blocked the gate, so we couldn't enter the Department of Health in Pretoria at the front gate. We had to be smuggled to the back. And that's where my question starts from, because it's really about your thoughts around their conditions of employment, their career progression, and what are your thoughts in terms of how that can be done? I have quite a lot of information around that. I just want to kind of hear your reflections around that, because the strike that blocked us to be smuggled into the department just show that there's quite a lot of issues around that. So I'd like to hear your reflection around that and what you think can be improved and what you found through your study.
Highly esteemed opponent, I thank you for your compliment and your question. And as I said previously, the lay counsellor role and community health workers as well has been challenged and marred over the years regarding their formalization. I know a couple of years ago, there was a directive from the then Minister of Health to employ them as permanent staff, and they were all rejoicing that this is it, we're now permanent staff, and it never really materialized in terms of actually having contracts and actually having some sort of conditions of employment instituted within the health system. And there's been, I wouldn't want to say a fight, like a debate between the government and the unions that are representing the lay counsellors, because now the unions are actually sticking to the health minister said they must be permanently employed. We have come to an agreement, and that's that. And now what the government is proposing is a sectoral determination. I think that's the correct phrase, which essentially, categorizes them as certain type of health workers and determines their scope, determines their working hours, determines their places of employment, determines their training requirements, and so forth. And the lay counsellors in Johannesburg, the ones that I actually worked with for this project, by the time we had finished the project, they had been employed as permanent employees in their clinics. They were rejoicing. Now I feel like I can go to the tea room and drink tea with my co-workers. However, how that has translated in terms of actual professional belonging and professional determination in terms of, as this type of professional, this is what is expected of you. As this type of professional, this is how we'll invest in terms of capacitating you. As this type of professional, this is how we're going to support you. It wasn't really, it didn't materialize for me. It's like, yes, they can jump and say, we have contract, but that's what I think that should be addressed when trying to address the formalization of these cadres, is that it's not just a contract, is what is expected of me? What skills am I required to have? Who am I supposed to, where does my scope start and where does it end? How long should I work? Who do I report to? And what do I expect from my employer and from the system to empower me, to support me, to develop me? So I hope I sort of shed light into your inquiries.
Yeah, thank you. Thank you for that. Just one last, I don't know how much time I have. Do you, in your interactions and your work, I have my own personal opinion around this. Do you think lay counsellors and CHWs as well, the policy that guides their engagement with government, do you think there's a scope for them that could allow them to be upgraded, say, to be an assistant nurse, or, to move up instead of saying this is like your lifetime career, you're going to be a lay counselor till you die or till your contract ends? What are your thoughts around that?
And
Can you please keep the answer short?
okay, thank you. I think it's possible. It requires investment in terms of the health system in building this cadre. And that investment, requires, political will or will from the decision makers to make that framework. I remember at the beginning of the HIV program, there were some lower cadre workers that were actually upgraded, I think, to social auxiliary worker. And there was a system in place to be able to implement that. And what's to stop that happening with lay counselors, especially the experienced ones, the ones that have, enough training and background to be actually upgraded to be some sort of higher level counselor to supervise and oversee lower cadre counselors.
Thank you.
Thank you very much. The opposition will now be continued by Professor De Vries, Professor Emeritus of Health Promotion at Maastricht University.
Yes, thank you very much, Mr. Hector. Actually, first I'd like to congratulate you. It's an important day for South Africa, not only because of the elections, of course, but also because of your graduation to a PhD position now, and I hope that will bring every success. And now, this also relates a bit to what I'd like to talk with you about. I think in the earlier answers that you gave, you refer actually to organizational changes. And that has to come about in some way. And I think the government will have a very important role in that. Being a social and organizational psychologist, I was a little bit disappointed, I must say, because indeed in chapter 1, I was looking at the different models that you present, and there are many, let's say, non-personal factors that you introduce, both at the interpersonal, so friends, peers, family, organizational, community levels, but slowly they sort of disappear, and you go back to, let's say, the motivation of the lay health counselors and also the way they treat, let's say, the people they contact. Was it a deliberate choice, or was it just because it so happened? Could you tell me something about that?
Highly esteemed opponent, thank you for your compliments and for your question. And, I'm glad you brought that up in terms of the counselor as a whole. So I think, the limitations of the influence that a training can have on, other facets of your life is something that I think I've come aware of in terms of, going through this process. And I agree that, those areas are important, and although we didn't address them directly in the training, they are still important. And it's something that I think that we could have done better or more intentionally.
So you would do if you were to repeat this whole.
If I was to repeat this, I would have more resources, I'd have more knowledge, and I would then try to cover all the bases to make sure that not only the training and motivation and knowledge are addressed through a training process like this, but to also acknowledge the other factors and, be intentional in terms of trying to actually address them.
Actually, this also brought me to the idea that using lay counselors might be, let's say, a choice of poverty. Because I think there might be other persons that could even motivate, let's say, people who are diagnosed, to get tested and then treated in a more effective way, maybe. Some people just want to be advised by a doctor, a medical doctor. Some people want to be advised by peers or by people who also have been through the whole motion of getting tested and going into treatment. I remember Professor Sivunda's thesis about prison inmates who influence each other or try to motivate each other. So are the lay counselors the most effective way of approaching let's say, the final target population? And I think you have to keep the answer short because otherwise the director will tell you so.
Thank you for your question. So I would say that, I would like to try to be more positive in terms of the lay counsellor cadre was as a result of adaptation or, trying to meet the needs of the population with limited resources. And this was through the task shifting strategy where, they were put in place to do the HIV testing services. And yes, we'd all like to be seen by doctors at the clinic, but we have limited capacity in our health system, and we have to make do with what we have. Mm-hmm. And lay counsellors actually were born out of peer support that was there at the beginning of the epidemic, and some of them actually graduated and became support group leaders and ended up as lay counsellors. Yeah. So I do see them, a lot of them, especially because some of them are also HIV positive, as peer.
Only a quarter, huh?
Yeah.
But I also heard you, let's say, proposing that they might get a contract, and then they're not lay anymore, but then they'll be a professional. But I thank you for your answers. Give the floor back.
Thank you very much. The opposition will now be continued by Dr. Schneider, Assistant Professor at the Department of Health Promotion, Maastricht University.
Yes, thank you very much. Dear candidate, I would also like to compliment you on the work. For all the same reasons that have been mentioned, but I also looked at your resume and you also have some extensive experience in the field. So I think combined with this academic work, I think you are the right person at the right time, place. So keep up the good work, I would say. I also have some questions, and the two of us share something. We've both been trained in intervention mapping. And while I was reading your thesis, you know that normally in step 2, we develop a solution for a health behavior. So that would say, I don't know, adherence to therapy, uptake of therapy, and we have an intervention for that. In step 5, we then focus on training people to deliver that intervention. So the intermediaries, most of the time professionals, like lay counselors. However, while I was reading your work, I saw that you developed the training for the lay counselors in step 2. And I was wondering, and you can give a short answer because I have another question, why did you decide to focus that in step 2 and not look at that from an implementation perspective?
Esteemed opponent, thank you for the compliments and thank you for your question. So I think that lay counselors have, always been, the focus of what we were trying to do, and we were not quite sure how it would translate. And I think that's how we ended up, starting off right from the bat to say, these are the important agents in the health system that actually the patient, even before they get to know their HIV diagnosis, encounter. And that's where the impact would lie in terms of they're the ones that will actually determine, they have the most influence in terms of will I accept my HIV diagnosis? Will I take on treatment? But also, if I'm negative, will I change my behavior to remain negative? So I think that's how we came to the focus of lay counselors.
Yeah, and I was especially wondering on, because you now place the development of the training, so the training you're providing to lay counselors to give motivational interviewing, you sort of develop that in step 2. So you see it as I don't know, you also use behavioral change theories, individual theories, but in your work you also refer a lot to implementation terms that I'm used to hearing in an implementation context. You talk about fidelity, your performance objectives are about following the training, practicing the skills, adherence to practicing the skills. If you had phrased that, or if you had looked at that from an implementation context, maybe making use of more implementation-related theories, do you think you would have arrived at the same outcome? Or do you think that would have, that already gives my idea about it, but what do you think? Would it have changed the outcome?
So that's an interesting take on that. And I don't think that it would have changed the outcome as much. The use of language may, gather certain perspectives, from people from different background in terms of training. I'm an implementer. before my research days, I was implementing HIV programs, and I came with that mindset to this project. And I think maybe if I had come from another perspective, what you're saying in terms of intervention mapping as a seasoned intervention developer, maybe you would have come to a different process and a different training. But I think that if it was still me, this is how it would still be the same way.
Do I have time for a short question? Yes, because I didn't prepare this question, but I was intrigued by something you mentioned in your presentation, especially when it came to the last chapter where you also evaluate the trainer, because that's even another level. Like first you're training lay counselors, and then you also train trainers to train lay counselor, which is fascinating that you also managed to do that. But it seems like you included in that pilot study 10 lay counselors, so those are the people that need to be trained, but you included 42 trainers. So actually the experience you have with training trainers is larger than you have with training counselors. But it gets less attention in your chapter. So I was wondering, what do you take from the trainer part? If you were to, because scaling up is immensely important. What would you train? How would you change that training? What was the quality?
So the training of trainers approach provided an opportunity to disseminate the training wider. And if I could do things differently, and it was an urgent request, if I remember correctly.
Yes.
And we had to, if I had to do it differently, I'd be more. I'd invest more time. I'd invest more follow-up after that, because once we trained the trainers, we weren't involved in them passing on the training to their lay counselors. But we did speak to them to understand, what were the challenges in terms of implementing the training. Did the training that we provided to you help you in terms of passing on the training to your lay counselors? So what I take from that is that we should actually invest more in terms of the training of trainer approach, because that's where this training will be implemented widely. But we also want to make sure that the key principles that we put in the training in terms of the behavioral theory, the different training approaches that we implemented, that once they go down to other levels, that they are maintained in terms of being quality-based and are effective to the people that they are being passed on to. So I would like another training of trainers, and we've had a new opportunity to actually pass on the training to another set of population, and lessons from this experience have actually put us in a better stance in order to be able to do it in the way that we would be actually better comfortable with for this new set of people that are going to receive the training.
Yeah, that's good. Thank you very much.
Thank you very much. The opposition will now be continued by Professor Kok, Professor Emeritus of Applied Psychology at Maastricht University.
Thank you. I'll skip all the compliments and just go to the question. You have a beautiful drawing on the front. What do you want us to understand from the drawing? What do you want to convey with the drawing?
Thank you, highly esteemed opponent, for your question. So the whole thing about lay counselors and the premise that they need support, I think that's even with the logo down at the bottom of the book that says Tusa Tusa. Tusa Tusa means helping you help. So we came with that premise that we want to help these people who are expected to help people who are at their most vulnerable situation in their lives. So the whole premise of this is we're supporting you. We're here to be able to support you to actually be more effective in supporting others. So that's how the logo and the title.
I noticed a kind of difference between the logo, the first logo, and the new one. The first logo looks like somebody takes you by the hand and brings you something. This is more reaching out. Is that coincidence or is that a choice?
it's coincidence, but now I can actually say that it applies. It applies to the context, because what we did is we tried to help grow these counselors and motivate them and increase their knowledge.
Yeah.
And the way that the next iteration that we did with the training is actually reach out to others in terms of providing that support to them and providing that capacity to them. So I can claim that now.
Okay. I have one more question if we have time. You skipped the social norm influence in the attitude social norm. That is unusual. So what exactly happened there that the social norm was not important?
So in terms of the social norms, I think that, although it was not, intentionally carved out in the dissertation in terms of addressing it, but I feel like, the way that we approached the training and the way that we engaged with the lay counselors, we actually spoke to, their social norms in terms of what is a counselor, how are they regarded within, society, and, how are they regarded within their work environment, and also what is the, what is society expecting of, these cadre of people. So I think that it may not be intentional or carved out in the same way in the thesis.
Idah Mokhele, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return in this room.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side. 10 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if it's questions that you got to go back for
Editing the video recording.
I think it was leading. I can't read your mind. Years can't fly by. Don't waste all your time. Cause I'll go the extra mile.
Right now, so I won't be distracted by the picture anymore. Let's go with the distribution in the defense. So I will go around the opponents almost the same order and ask you your appreciation of defense and the distinction. Thank you, instructor. I think that Idah gave a good answer, but she didn't say much to my question.
Challenge and we all in, it's a better future that we go for. And even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown.
Recording in progress.
Southside, 10 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and night. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if it's Years can fly by now, don't waste all your time. 'Cause I'll go the extra mile.
Nee, het is niet de bedoeling, maar het ging even ook met de Zoom te straks al. Dus ik ga even straks na de sessie gaan we alles oplossen. Maar het is voor de rest nog goed gegaan. Dat is geen probleem. Dankjewel. Geen invloed verder hoor, maar niet druk.
Ik denk, I've been on both ends, you don't want to hear the conversation. No. Which of course is positive or whatnot, but it's a different context. Yeah. So, yeah, I didn't see, I was like. And he's doing like. Are you American? I'm Canadian. Oh. Because I'm like, you've got an accent, but you speak Dutch. I've been here for a long time. I've been here since 2001. Oh, wow. No, I'm excited to hear about Mandy's work. She's very enthusiastic and she's been, she's been an advocate. In terms of the HIV space, so it's good. Yeah. So we're right at the beginning. You haven't intention or no? We're right at drafting the research. So we were from there. Yeah, now we need to be part of the support group. Yeah, but that's exciting for us. I know Dorina was talking about it for a while, saying that, you should go to Maastricht University, so that she found somebody that she would do. Has she been there? No. She was hoping to get a scholarship for IAS in Munich, but that didn't come through, and then she would have come to the intervention after school, and then on to Munich, but that didn't come through. But she does a lot of work for IAS. Yeah, I'm surprised, And she's normally part of panel discussions there or chairing things and so forth, so that's really surprising. Yeah, it is. Hopefully they'll find funding for hopefully, yeah. And you ladies don't have to do any reading. She was here first. I don't have my glasses. She was here first, and when they were giving us instructions in terms of what to do, she's like, she's the one who's going to do the reading. Lisa, right? No? Yeah, Lisa. So now I have a picture. And Desiree, and both with in the secretariat. Yeah. No, I'm not. I'm doing finance and psychology. Okay. Yeah. Mariana was on vacation. Oh, so good. It's good to be on vacation. And you get to do all the work. Yeah. That's just fun. But now we have faces and names because we've emailed us. Yeah. Because you came after I left, but the connections are still very. Yeah. Sarah. So this is her first weekend, and now she knows what to do. That's why, yeah. This is your first party visit. Oh my God. It's like Vanna White. I really. So I have to ask, like, what is the paradigm? Yeah. Like, no, it's ceremonial. It's ceremonial. A bridesmaid or something.
it's cold
I
for
thought
you.
the first time I went to South Africa was in July, and I was like, I froze because the houses are we're not insulated. Not insulated. We were there, and I had we went out and bought gloves, and space heater, and
18 degrees.
18 degrees.
Okay.
So 18 here is like the sun's coming out, it's dry. 18 is like it's cold and damp.
Okay.
It feels like it's in your bones, right? It's like it's
And
inside your body.
And last year we had snow for the first time in something.
No.
And we had not.
No, we're not. It's a disaster.
Not equipped for that. People were excited snow. I'm like, we're gonna freeze.
We can't drive any car.
Actually, we don't know what to
No,
do.
it's distraction.
Snow tires? What's that?
The Dutch don't know how to do a snow either. Every time it snows here, it's a disaster.
The trains are not.
It just it's very ineffective.
Yeah.
Oh, I didn't know. I thought you guys were.
No, I grew up in Canada. They know what to do. with snow.
I was like, you guys shut down for like half of the year or something. Because I was in Canada last year for that reason. Not last year, the year before.
When it was in Montreal.
Yeah, and people were so excited. Like, it was amazing. People were asking why, parties and whatnot. Like the locals.
Yes.
And then somebody was like, no, it's because it's expensive to snow there.
Yeah.
In winter.
It's very cold.
Then like you don't go.
Yeah, but what happens now here in Holland with all the rain is also not really more.
Not for me. We're supposed to be able to, swim in outdoor pools.
Yeah.
Drink wine outside on the patio.
This year is a little bit of that.
No, it's, people can argue this kind of thing before.
Yeah. And you see it.
When you see it.
Especially when you are getting now snow for so many years. And we don't have any snow anymore, or I mean very less. The winter, you don't need any jacket for the winter. I mean it's warm enough.
And the floods and the it's something that we are not, like as I said, the school users we're not equipped for. We don't have the double glazed windows. We don't have internal heating like in the US.
Okay, you are taking ice bath. Like me, even if it is minus 4 degrees outside.
Ice baths?
Yeah.
Wim Hof, maybe?
Yeah.
Oh.
Yeah.
In the snow.
I have in my garden an ice bath. You have to experience yourself actually. It's it gives you the first minute is oh my god and everything is saying don't do it, but when you're laying down it's just like everything's just relaxed and
it's like your body is in
if
shock.
you get it out,
used to it.
then you have the feeling that you can take the whole world on you and it's so magical. I cannot explain it because everybody experiences differently. For me, it's perfect, but I'm using that more because I'm 53 and I'm on say the menopause.
Menopause.
Yeah. So I'm happy to sometimes to cool down.
Oh yeah. One of our professors was here today to discuss university. So when she came for the she had this thing over the
I don't know. Keep checking.
But
it's inappropriate in dissertation contexts for people from there and come here. I've done it.
Oh, okay.
she had this thing over like looking at headphones. So I'm just like I've never seen people use a fan. I have to keep cool all the time.
Because this summer, now we are going in August in Spain. It could be
very hot.
I love summer, but I prefer to stand inside with the aircon and then or early in the morning or in the evening and coming out because then I can drink more.
During heat waves, you can imagine
sister has a home over there, and we're going over there for just a few weeks. Yeah.
So, Dr. Ibisomi, they're going to take us to the room where the defense was.
Idah Mokhele, the degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Ruiter is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
Thank you. By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Idah Mokhele, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with a degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university. Dr. Mokhele, I already said in the room just now with the evaluation, it was a real great pleasure to be on board with this project. I was very happy that your supervisor in South Africa, Dr. Onoya, invited me. I think we had a great project, and I invite your supervisor now to take the floor and say some words.
So I have a few things written down so I don't go over the time. So Idah, I'm really honored to be given the opportunity to say a few words on this special day. You've really shown great capacity and intelligence throughout your PhD journey, and I think the panel here today was able to see that. And I'm really proud of your achievement today. The project that you took on was really significantly, it was significant for the country, but it was also a challenge, especially when we talk about the stakeholder engagement throughout the intervention mapping process. So I think that will stay with you going forward. But with every request, you really rose to the challenge, and you know the product of your work is evident. Later, I heard that this was going around, that you were terrified all the time and you weren't quite sure what you were doing. And I don't know why that would be. I'm still shocked every time I remember that. But I'm glad that you found the courage to keep saying yes at every turn, to keep saying yes, to bring fresh energy, innovative thinking, and the results are outstanding. Lastly, your commitment to this work was evident recently as we begin to turn this around and try to think about the best way to disseminate the work. COVID was an interesting time to try to do that, but well done. This is very well deserved, and congratulations.
Dear Dr. Mokhele, also on behalf of Maastricht University, I congratulate you with the degree you have acquired. And before officially closing this session, I will make some procedural announcements. The idea is that somebody takes a picture of you and the committee here with the online opponents in the background, and later the same will be done, a picture on the big stairs, and after that we can move to the reception area. Thank you very much. I now officially close this meeting.